Welcome back everyone. Today's video is going to be very interesting. It is about composite restoration on a tooth. Please watch to the video and any questions please feel free to ask in the comment section. Hello and welcome back everyone. This is a pre-treatment photograph of today's video and we can clearly see that today we are going to prepare a buccal pit and the occlusal table. Now let us start with the video. Right now I am using round burr number 31 and it is of diameter 1.4 mm. You can clearly see that I am actually using brushing strokes on my tooth. It is much easier to remove the dental caries using brushing strokes whenever you are using new burrs. Most of the time we don't realize that the burr has basically worn out, so we have to be much more aggressive with those burrs, but in turn aggressive movements to remove dental caries during cavity preparation would lead to microscopic damage of enamel rods and dentinal tubules, in turn resulting in dentinal hypersensitivity post-operatively. For now, the proposed outline form of the cavity preparation is involvement of occlusal table and the buccal pit by connecting the buccal tooth structure, so buccal extension. And it is always necessary to have a very good knowledge of steps of cavity preparation during any kind of restoration, either advanced composites or conventional amalgam fillings. You can see that the buccal lesion is going so deep inside the tooth structure. It is axially progressing inside and afterwards clearing much of the dental caries. It is now clear that it is impossible to make it as a buccal extension cavity. So here the outline form changes and becomes an occlusal table along with the involvement of buccal pit. Whenever you are using modern composites, you don't have to worry about being much more aggressive in cavity preparation and maintaining primary or secondary retention form along with the resistance form. You can be conservative as much as you want to be, but keeping in mind proper isolation and definitive involvement of carious zones. Never be very aggressive during tooth preparation because, as I said, in turn it would lead to dental hypersensitivity. Also, this patient is actually a case of dental fluorosis, and you can see by the texture of the tooth at this point. You can also shift to burr number 46. I am right now continuing it with the burr number 31. I feel that using burr number 46 with a much smaller diameter, you can be conservative definitively. But when you go deep inside the occlusal table, you let go of the composite extensions inside the cavity preparation, which are much more prone to fracture during or after the restoration under the compressive load, in turn compromising the secondary resistance form. We are doing today the restoration using Ivoclar's flowable composite. This is very important whenever you are removing the etchant from your cavity prepared. Many practitioners actually flush off the etchant. It is basically around 35 to 37 percentage phosphoric acid, which is very volatile. So flushing off the agent is not pleasant for the patients, and also it may create volatile fumes which may get deposited inside your operatory atmosphere, and the next day you might feel some odor whenever you turn on the aircon. I have practically felt it, and hence I have shifted to this way of removing the etchant from the tooth surface. It is much more safer. Even during drying of the cavity, I prefer to protect the moisture inside the dentin, and I only dry the enamel part because the dentinal tubules are open right now, and drying them completely would in turn result the movement of dentinal fluid inside, and in turn it may lead to post-operative dentinal hypersensitivity. Proper isolation is always a key factor in doing any composite restoration, and the life of composite restoration is always dependent on how you do isolation. Today we are going to isolate this case using cotton rolls. Rubber dam is the best way to isolate any tooth. Rubber dam is basically the need of our today, and you can practically do each and every case in rubber dam. Right now I am placing the base composite, and this is I am using 3M's bulk flow composite or bulk fill composite, just to provide a firm base to our flowable composite. If the composite filling is done in a reverse way, if you are using flowable composite in the base of cavity and then afterwards placing the bulk fill or the packable composite on the top of flowable composite, then it becomes the sandwich technique of composite restoration. There is one more technique of restoration called as by the same name sandwich technique, but it is of conservative dentistry, in where you use glass ionomer cement and composite cement both at one time. Flowable composite are actually very best at maintaining a C factor. The C factor of flowable composites is very good. You can be so sure about the retention of composites, and the shrinkage is is limited. But as it is said that every advantage of anything comes with its own disadvantage, and so in this case, using flowable composite would lead to poor anatomic outline. However, you can provide the anatomy using composite formers. This is actually a probe that I am using right now to provide a light or a moderate form of anatomic outline to the restorative cement. Then afterwards we will finish it with the finishing bar. Specific instruments are also available. These are called composite anatomy formers or composite formers. You can use them also. They are basically the same thing but with very fine needle at the end. It is actually a real struggle to do this thing, but afterwards whenever you are completed with the anatomy outline formation, you can easily finish the cavity using finish the restoration using the finishing bars. Now at this point you can also add staining agents in the composite. However, the patient was not comfortable, and so I have not added the staining agents on the buccal aspect or the facial aspect of the tooth. Because the tooth is under the effect of enamel fluorosis, adding of little bit of tint or staining agents would actually create very good effects on the overall outlook of the restoration. Finishing the restoration using finishing bars creates very much of micro abrasion on the surface. Along with that, there are some nits and scratches also formed on the surface of the restoration. So it is a must process to finish off the composite, followed by polishing of the composites. I personally prefer Waco polishing pastes for my composite restorations. And in this video, however, we have not covered the polishing of composites. I'll be making a separate video for composite restorations polishing. This way of finishing composite restorations takes a very high amount of dexterity, operating dexterity. After finishing the restoration, I checked about the high points and also reduced them. It is very important to reduce the high points. However, with flowable composites, there is one advantage of using mylar strips on the occlusal surface and then telling our patient to bite on it. This is how I actually skip one step before performing the high point reduction. You can also get a proper anatomy outline using the opposing structures. Now this is the unpolished form of a finished tooth structure, the composite restoration. We have reduced the high points also at this time. This is where a post-operative and pre-operative photographs are very noteworthy. We can compare and contrast both of them. I have placed a post-operative photograph in the end of the video. After polishing of the restoration, this is the post-operative photograph after polishing the restoration. And I always like to preserve both the photos, post-operative and pre-operative, so that we can, again I am saying, we can compare and contrast, and we can also find the mistakes if any. Thank you for watching today's video, and any questions you have, please feel free to ask in the comment section. Thank you so much.